I want you to do something for a second. If you're not driving, just take a look down at your own arm. Like, really look closely at the surface of your skin.
Yeah, we tend to just think of it as our body's wrapping paper, right? Like something that's just kind of there.
Exactly. But I want you to try to imagine that incredibly thin outer layer as this microscopic, highly engineered fortress. Basically, think of it as a tightly constructed brick wall whose entire relentless purpose is to keep water locked inside your body and the entire outside world, so like bacteria, allergens, pollutants, exactly where it belongs, which is outside.
Right, outside the gates.
Yeah. But what happens to that impenetrable fortress when a single genetic typo stops your body from manufacturing the mortar for that wall?
Well, I mean, it creates a profound systemic failure of the body's primary barrier system. When that structural mortar goes missing, the wall doesn't simply crumble and fall apart in an obvious way. It fundamentally alters how human tissue interacts with the surrounding environment. And that triggers this complex cascade of events that extends, way beyond what we casually dismiss as just dry skin.
Okay, let's unpack this. Welcome to the deep dive. Today we are looking at a really fascinating stack of your dermatological and medical notes centered on a condition called Ichthyosis vulgaris.
Which is actually the most common disorder of skin keratinization.
Right, and our mission today is to decode this condition, taking you from the macroscopic symptoms you can see with the naked eye all the way down into the microscopic cellular defects. We are going to explore how one missing protein acts as a sort of biological wrecking ball, triggering a domino effect that can ultimately rewrite how your entire immune system behaves.
And to really appreciate those systemic domino effects, we have to start with the physical presentation. The clinical naming of the condition actually gives us our most immediate visual clue. So ichthyosis is derived from the Greek word ichthys, meaning fish.
Fish, right?
Yeah, and vulgaris is just the Latin term for common.
And the notes highlight just how common it actually is, affecting roughly 1 in 250 to 1 in 1,000 people, which is wild. And that fish descriptor, I mean, that is pointing directly at the signature scale pattern, isn't it?
Exactly. A patient usually presents with these fine white or gray polygonal scales. And if you look really closely at the individual scales, they are adherent, meaning securely stuck downright in the dead center. But they feature these distinct, free, upturned edges.
Oh, wow. So it looks very much like microscopic dry leaves peeling up off a sidewalk or something.
That is a perfect way to picture it. And physicians are also looking for another highly characteristic physical marker on the patient, which is hyperlinear palms and soles.
Right, the accentuated lines.
Yeah, the normal creases and lines on the palms of the hands and the bottoms of the feet become deeply accentuated and physically exaggerated. It serves as a really primary diagnostic indicator.
Okay, so we know what the surface looks like, but the distribution on the body is what really caught my attention in the notes. Like,
Yeah.
the scales heavily colonize the extensor surfaces. So we're talking the outer arms, the outer legs, the shins. But they remarkably spare the flexures,
Yes.
meaning the antecubital and popliteal fossa are totally clear. And wait, if every single cell in this person's body carries the exact same genetic mutation, why on earth would the condition just magically skip the bendy parts of the arms and legs?
What's fascinating here is that the condition isn't skipping those areas genetically at all. I mean, the underlying genetic defect is actively present in the elbow and knee pits.
It is.
Oh, yeah. The difference lies entirely in the localized biomechanics of those specific joints. The flexures are basically microenvironments of higher relative humidity and, crucially, constant mechanical friction.
Well, because of movement.
Exactly. Every time a person bends their arm to eat or bends their knee to walk, skin is forcefully rubbing against skin. That continuous physical friction, combined with the trapped localized moisture, well, it mechanically disrupts the scales.
So the scales are constantly trying to form in the elbow pits, but the simple act of human movement acts as a relentless physical exfoliator. Like, the body is essentially sanding away its own symptoms in those specific spots.
That is exactly what's happening. And that flexural sparing becomes a vital piece of the puzzle for a physician trying to rule out other disorders. But, to understand why these scales form everywhere else and why they adopt that specific upturned leaf shape, we need to dive beneath the surface. We have to look at the precise cellular architecture of the stratum corneum, the outermost layer of the epidermis.
Which brings us back to that microscopic brick wall analogy.
Right. So in a healthy, fully functioning stratum corneum, you have a barrier made of 15 to 20 precise layers of corneocytes. These are our bricks, and they are anucleate, meaning they have shed their nucleus, and they are completely flattened out to maximize their surface area. These flattened bricks are securely embedded in our mortar, which is a highly specialized lipid matrix composed of ceramides, free fatty acids, and cholesterol.
So you've got flat, wide bricks and a strong lipid mortar creating an airtight seal. But Ichthyosis vulgaris disrupts that blueprint right at the foundational level through a loss-of-function mutation in the FLG gene.
Yes, on chromosome 1q21.3.
Right. But what really matters here isn't the alphanumeric label of the gene, it's the blueprint it destroys. The mutated FLG gene completely fails to encode a massive precursor protein called profilaggrin.
And without that precursor, the subsequent biological chain reaction just stalls completely. In a normal processing environment, profilaggrin is converted into filaggrin in the granular layer of the skin.
Okay, and filaggrin does what exactly?
Filaggrin has a very specific, almost mechanical role. It aggregates keratin intermediate filaments. Basically, it binds to the structural scaffolding inside the cell and physically collapses it.
Whoa, collapses it.
Yeah, forcing that skin cell to flatten out into that aerodynamic, tight brick shape we need for the wall.
Oh, I see. So without filaggrin acting as the cellular trash compactor, essentially the cell never collapses.
Right.
So instead of a flat, tight brick, you're left with a bulky, irregularly shaped cell that just doesn't fit neatly into the barrier.
Exactly. But the structural failure is really just the first phase. After filaggrin completes its job collapsing the cell, it degrades into amino acids known as natural moisturizing factors, or NMFs.
Right.
And these NMFs serve two critical functions. They pull and hold deep internal hydration within the skin, and they maintain the skin's acidic pH mantle.
Okay, so no filaggrin means zero natural moisturizing factors. The skin is robbed of its internal water supply, and without those specific acids, the pH of the skin tissue actually begins to shift, right? It becomes more alkaline.
Exactly. And that shift to an alkaline pH disables the skin's natural shedding mechanism. Normally, the dead cells are anchored together by these microscopic tethers called corneodesomosomes.
The tethers between the bricks.
Right. As these cells migrate to the very surface, specific enzymes dissolve these tethers, allowing the dead skin to flake off invisibly. But those enzymes require a strict acidic environment to function. In this new alkaline environment, the enzymes are paralyzed.
Wow.
Yeah. The corneodesomosomes never dissolve. They hold onto the cells tightly, leading to a state medical professionals term retention hyperkeratosis. Basically, the dead cells simply refuse to leave.
Okay, so if I'm understanding the physics of this, it's like a brick wall where the mortar suddenly turns into a permanent superglue that just refuses to dissolve, while the bricks themselves are drying out, warping, and shrinking because they lost all their internal hydration.
That's spot on.
And those characteristic upturned edges on the scales we mentioned earlier, that's the cell desperately trying to peel off and shed at the outer edges, but remaining permanently glued down in the dead center.
Exactly. The center is locked in place by those paralyzed corneodesmosomes, while the physical forces of the environment act on the edges. It creates a structural traffic jam on a microscopic level.
It's an entire mechanical collapse, cascading from just one single missing precursor protein.
Right.
But how does this structural traffic jam translate to a pathologist? Like, if someone takes a biopsy of this skin and puts it under a microscope, what are they actually seeing?
Well, when a pathologist reviews an H&E stain, which is the standard tissue dye used to highlight cellular components, they observe very specific hallmarks. Under low magnification, the primary finding is orthokeratotic hyperkeratosis.
Okay, lots of syllables there. Hyperkeratosis indicates a massively thickened outer layer of the skin, which perfectly aligns with our traffic jam of retained cells.
Right.
But orthokeratotic means that despite the massive buildup, these cells have correctly lost their nuclei. Like, they died on schedule, they lost the nuclei on schedule, they just never vacated the premises.
That detail is actually a critical fork in the road for diagnosis. If a pathologist examines a similarly thick layer of scales but notes that the nuclei are still intact inside the cells, which is a state known as parakeratosis, they immediately rule out Ichthyosis vulgaris.
Because retained nuclei points the diagnostic compass squarely toward other conditions.
Yes, specifically toward conditions like psoriasis. Psoriasis features parakeratosis. Ichthyosis vulgaris features orthokeratotic hyperkeratosis.
Here's where it gets really interesting, though. If the body is stubbornly retaining all these scales, stacking up this massive thickened layer on the surface, shouldn't we expect to see extra of everything else underneath it?
You would think so, yeah.
Right. Why do the notes highlight that the layer directly below the surface, the granular layer, is either incredibly thin or entirely missing?
This hypogranulosis seems totally counterintuitive.
It does seem paradoxical to have a massive overgrowth on top and then just a void directly beneath it. But following the biological mechanism explains the illusion. The granular layer earns its name because in healthy skin, it is densely packed with keratohyalin granules, and those specific granules are constructed entirely out of filaggrin.
The exact precursor protein the mutated FLG gene is completely incapable of producing. Exactly. Because the genetic typo halts the manufacturing of filaggrin, those keratohyalin granules never exist in the first place. Since the granules are the physical structures that absorb the dye and make that specific layer visible to the pathologist on an H&E stain, their absence means the entire granular layer essentially vanishes from view.
Oh.
The pathologist sees a normal base, a normal middle layer, an invisible void where the granular layer should be, and then a massive traffic jam of scales on top. The invisible layer is the absolute diagnostic smoking gun.
Okay, so what does this all mean for a newborn? If this is a fundamental inherited genetic mutation that is baked into a person's DNA from the very moment of conception, why do the notes state that babies with this condition are born with perfectly normal skin? Like, why does the visible onset reliably delay until 3 to 6 months of age?
This raises such an important question about the profound impact of environment on genetic expression. For the first 9 months of development, the infant exists in a highly protective, aqueous intrauterine environment. The baby's fragile skin is completely enveloped in the constant, heavy hydration of the amniotic fluid.
Right.
Furthermore, the infant is passively benefiting from the mother's functional filaggrin and barrier capabilities.
So the environment is essentially masking the genetic failure. The defect only reveals itself once the infant leaves that aquatic environment, hits the dry air, and is forced to rely entirely on its own compromised barrier to retain moisture.
Exactly. The transition to a low humidity environment forces the skin to attempt a barrier function it physically cannot perform, and that's what triggers the onset of the scaling between 3 and 6 months.
Makes total sense.
And while the scaling persists lifelong, though it often improves as patients age or relocate to highly humid climates, the real danger lies in what that broken barrier allows into the body. The clinical notes heavily emphasize the connection to the atopic triad.
Right, I saw that. The FLG null mutations driving this skin condition are the single strongest genetic risk factor for developing atopic dermatitis, or eczema, which shows up in 30 to 50% of these patients.
That's a huge correlation.
They also frequently develop keratosis pilaris, where excess keratin plugs the hair follicles, creating those rough, permanent goosebumps on the upper arms and thighs. Just another location, another traffic jam. But the atopic triad isn't confined to the skin. The triad refers to eczema, asthma, and allergic rhinitis.
Yes.
So my question is, how does a missing skin protein on your arm actively cause asthma in your lungs?
If you connect this to the bigger picture, the skin isn't just a physical wrapper, it is our primary immunological shield. When that epidermal barrier is structurally compromised, you experience significant transepidermal water loss, meaning the deep hydration simply evaporates. But a barrier that lets water leak out also lets foreign invaders leak in.
Right.
Environmental allergens, we're talking dust mites, pet dander, pollen, they penetrate deep into the living tissue of the dermis, far deeper than they ever should.
So the microscopic fortress is completely breached. The walls are down, and the allergens are just walking right inside the gates.
Exactly. And when those foreign proteins continually bypass the physical barrier, the immune system's localized dendritic cells flag them as severe threats. This triggers a massive systemic immune response known as a Th2 polarization.
Okay.
The body begins aggressively producing IgE antibodies against these incredibly common environmental proteins, becoming completely hypersensitized.
But because the immune system communicates globally, that hypersensitization doesn't just stay in the arm where the dust mite entered, does it?
Not at all. The hypersensitive immune cells travel throughout the entire body. They colonize the mucous membranes in the lungs and the nasal passages. So the next time that patient simply inhales a dust mite, the now primed immune system in the lungs launches a massive inflammatory attack.
Wow.
Yeah, restricting the airways and triggering an asthma attack or severe allergic rhinitis. A structural failure in the outer wall recruits and destabilizes the entire internal defense network.
It really emphasizes how dangerous it is to view the body as just a collection of isolated parts. Everything is connected. Up to this point, we've focused on the classic, inherited timeline of this condition starting in infancy. But the sources throw a massive diagnostic curveball. called acquired ichthyosis vulgaris.
Yes, acquired.
If a 55-year-old patient walks into a clinic and suddenly develops these exact same fine, white polygonal scales with the exact same invisible granular layer on the biopsy, what is happening? I mean, their genetics certainly haven't changed overnight.
Adult-onset acquired ichthyosis is treated as a severe medical alarm bell. When this identical clinical picture manifests out of nowhere in an adult, it demands immediate, aggressive investigation for underlying systemic diseases.
Like what?
Most notably, internal malignancies. The primary culprit is often Hodgkin lymphoma, but it can also signal mycosis fungoides or other lymphoproliferative disorders.
So the body is fighting something else entirely.
Right. The immune system's crosstalk, while fighting the cancer, somehow suppresses filaggrin production or deeply alters lipid metabolism, perfectly mimicking the inherited genetic defect. It can also be chemically induced by certain medications like nicotinic acid or cimetidine.
The sources also caution physicians to distinguish it from other inherited conditions, specifically X-linked ichthyosis, which, according to the notes, only affects males, presents with large, dark brown scales instead of fine white ones, and actually does colonize the flexures.
Yes.
Meaning the elbow and knee pits are covered in scales in that condition. It's driven by a completely different enzyme deficiency, so it behaves completely differently. But once a physician isolates the diagnosis to classic inherited Ichthyosis vulgaris, how do they fix it? Considering this is a fundamental genetic defect programmed into the DNA, surface lotions feel like, I don't know, putting a Band-Aid on a broken foundation.
Yeah.
We must be using systemic drugs to force cellular turnover, like oral retinoids, right?
Right. Actually, no. If we connect this to the bigger picture, deploying systemic retinoids is actively contraindicated for isolated Ichthyosis vulgaris.
Oh, really?
Yeah, you have to carefully weigh the risk-to-benefit ratio. Systemic retinoids carry significant heavy side effects across the entire body. We have to remember the exact mechanism of this specific disease. It is a localized retention issue. It's a superficial traffic jam caused by paralyzed corneodermosomes.
Okay, so treating this with a systemic drug would be like tearing down the entire house just to fix the mortar on the front porch.
Precisely. The management strategy specifically targets the mechanical failure. We utilize topical keratolytics like 5 to 12% lactic acid, salicylic acid, or 10 to 20% urea.
Which do what?
These specific chemical agents act to decrease corneocyte cohesion. Basically, they chemically melt the retained superglue holding the scales together, allowing the tissue to finally desquamate.
Oh, nice. And once that superglue is melted and the dead traffic jam is cleared, you immediately follow up with heavy emollients preparations packed with ceramides and petrolatum to physically stand in for the missing lipid mortar, restoring the barrier function from the outside in and trapping the water before it can evaporate.
Exactly. You are meticulously replacing the structural components the body cannot manufacture, directly resolving the pathogenesis without exposing the internal organs to harsh systemic medications.
It's incredible. What initially looked like a simple case of dry, flaky skin has really revealed itself to be a masterclass in physics, cellular engineering, and immunology. We've traced how a single genetic typo stops the production of profilagrin. Without it, the skin cells can't flatten, the hydration evaporates, the acidic pH neutralizes, and the enzymes that shed dead skin are permanently paralyzed.
Which leaves the patient with an impenetrable traffic jam of dead scales on the surface and a completely invisible granular layer under the microscope.
And most critically, we saw how interconnected the entire human machine really is. You know, a microscopic loss of Norder in the skin's outer fortress allows everyday allergens to breach the walls, triggering an aggressive immune polarization that can ultimately manifest as asthma in the lungs. It is a brilliant, if terrifying, reminder that every system is in constant communication.
It demands that we respect the skin not merely as a passive covering, but as a highly active, deeply vital organ system that guards the entire internal environment.
It really does. And it leaves me with one final thought for you to ponder. We discussed earlier how maternal filaggrin and the constant heavy hydration of the amniotic fluid completely protect an infant's skin while they are developing in the womb, basically masking the genetic defect until they hit the dry air.
Right.
So if we know that specific environmental conditions can effectively override the genetic mutation, could the future of treating these deep genetic skin disorders lie not in applying daily peeling acids or immune suppressants, but in bioengineering synthetic amniotic microenvironments?
That's a fascinating idea.
Like, could we somehow create wearable, invisible barrier technologies that permanently reteach the skin how to behave? acting as a permanent surrogate for the mother's protection long after birth. Because if we can permanently replace the mortar without tearing at the wall, maybe we can finally secure the microscopic fortress.